This voiceover is a quick guide to postpartum hemorrhage, one of the leading causes of death for postpartum women worldwide. In common practice, a postpartum hemorrhage is defined as blood loss greater than 500 milliliters after a vaginal delivery or greater than 1,000 milliliters after a cesarean with normal vital signs and lab values. ACOG, the American College of Obstetricians and Gynecologists, defines early postpartum hemorrhage, which is a hemorrhage that occurs within the first 24 hours after delivery, as the cumulative blood loss of greater than or equal to 1,000 milliliters, or blood loss accompanied by signs and symptoms of hypovolemia within 24 hours following the birth process. So what you would see would be a decrease in the hemoglobin and or hematocrit by 10% post-birth. Severe bleeding postpartum is when a woman will saturate a peri-pad within 15 minutes. Uterine acne can cause the uterus to remain foggy after delivery, and vigorous fundal massage would be needed to maintain the tone, and sometimes even that isn't enough. Tachycardia and decrease in blood pressure, some of the signs of shock, are late signs in postpartum hemorrhage because of all that physiological changes of pregnancy where they've had the increased volume of both plasma and red blood cells. Secondary postpartum hemorrhage or late postpartum hemorrhage occurs 24 hours after birth up to 6 weeks. If you suspect a client is having a postpartum hemorrhage, think of the 5 T's: tone, tissue, trauma, thrombin, and traction. The most common reason for a postpartum hemorrhage is tone, or specifically uterine acne, the lack of tone of the uterus after the delivery. Then trauma, which would be caused by lacerations to the perineum or cervix, possibly hematomas, or uterine inversions, or possibly even a uterine rupture. Tissue refers to retained tissue or a retained placental piece. Thrombin or clotting, which is uncommon, refers to a coagulopathy such as a clotting disorder, like von Willebrand's disease, or if a client goes into DIC. Remember, women during pregnancy and immediately afterwards are in a very hypercoagulable state. And the 5th T is traction. And this is when someone pulls too hard on the umbilical cord, which could cause the placenta to come out in pieces and leave some behind, or in worst case scenario, actually invert the uterus. Uterine acne is the lack of muscle tone that results in failure of the uterine muscle fibers to contract firmly around the blood vessels when the placenta separates from the uterine wall. So the baby's born, placenta is delivered, but the site where the placenta was attached continues to bleed and will continue to bleed until the muscle fibers contract. When the uterus doesn't contract, the uterus itself will feel boggy or soft when doing a fundal check. Risk factors for uterine acne include any condition that might overdistend the uterus. So you're talking multiple gestations like twins or triplets, large babies, hydramnios or an inordinately large amount of amniotic fluid, multiparity, which means having had other pregnancies, because that uterus has been stretched out before and it might not contract back down well after birth. Sometimes what happens during labor can impact a woman's predisposition for postpartum hemorrhage, such as a prolonged labor, or on the flip side, a precipitous delivery. Plus, the use of oxytocin for induction or augmentation is also associated with uterine acne and postpartum hemorrhage. Finally, if there is a retained piece of placenta, that piece will not allow the uterus to contract firmly and result in acne. A normal uterus for the first 24 hours post-delivery should feel like a firmed, contracted ball, roughly the size of a large grapefruit. It should be easily to locate at the level of the umbilicus. The lochia should be dark red, and the quantity would be somewhere between scant to moderate. Not all postpartum hemorrhage bleeding will be profuse and dramatic. A constant steady trickle or slow seeping of blood is just as dangerous cumulatively. So you want to be watching not only for large gushes, large clots, you also want to watch for that steady trickle of blood from the vagina. Oxytocin is recommended for all births as a prophylaxis against postpartum hemorrhage. It is given through an IV infusion where the oxytocin is diluted usually in about 500 to 1,000 milliliters of lactated ringers. Oxytocin is never given IV push. If there is no IV access, it may be given IM. Immediately following birth, the new mother is still one-to-one with her delivery room nurse, and as the nurse, you are likely the person who will first identify and initially manage uterine acne. If the uterus is not firmly contracted, despite the IV oxytocin, the first intervention is uterine massage. You will massage the fundus until it is firm and any clots that may still be in the uterus are expressed. To do this, you will place one hand just above the symphysis pubis to support the lower uterine segment, while the other hand gently but firmly massages the fundus in a circular motion. If this does not work, the issue may be due to a distended bladder. If the bladder is full, it lifts the uterus up and to the side, which will keep the uterus from being able to contract adequately. If these interventions are ineffective, further pharmacologic measures may be ordered. This could be additional oxytocin, methergin, Cytotec, or Hemabate, and we'll talk about those medications soon. At this point, if the bleeding is not stopped, we are likely starting to head to the OR, if you're not already there. You'd have already called for help, and the provider is likely still bedside giving orders for the medications you just gave. At this point, the client is looking at more invasive or surgical interventions. A balloon can be inserted into the uterus to act as a tamponade, or uterine packing can be inserted to try to stop the bleeding. A laparotomy may be performed to determine the source of the bleeding. The physician may put in uterine compression sutures or consider doing a uterine artery ligation or embolization. Finally, the last-ditch effort is to perform a hysterectomy. This is typically reserved as the last resort to save the life of the mother. On this slide, you'll see information about the 4 most commonly used medications when dealing with a postpartum hemorrhage. Couple key points to remember is that carboprost would not be used with clients with asthma due to the risk of bronchospasm, and methergin is contraindicated in the hypertensive client. Both carboprost and misoprostol or Cytotec can cause significant diarrhea. Click on the video to see a dramatization of a postpartum hemorrhage resulting from uterine acne. The second most common cause of postpartum hemorrhage is trauma, and we're talking about soft tissue trauma during delivery. It includes lacerations to the vagina, cervix, and perineum, as well as hematomas. Risks for trauma are similar to those for uterine acne, which makes sense if you think this through. For example, a large baby or a very rapid delivery are more likely to cause trauma to the birth canal. Additionally, the use of oxytocin to induce or augment labor and the use of operative delivery, such as a vacuum-assisted or forceps delivery, also increase the risk for tissue trauma. Lacerations of the perineum, vagina, cervix, and the area around the urethral meatus are the most common sites for tears. Most cervical lacerations are small and do not require repair. Perineal, vaginal, and periurethral lacerations commonly occur during the second stage of labor with rapid descent or with the use of operative delivery techniques. Lacerations are typically defined in degrees, first being the most superficial, to fourth degree, where the rectal sphincter is torn right through. Lacerations or trauma should be suspected if excessive bleeding occurs despite the fundus being firm and in the correct location. Bleeding from lacerations is typically bright red compared with the darker red of typical lochia flow. Bleeding can be heavy or seem minor with just a steady trickle of blood. Hematomas occur when blood enters loose connective tissue while the overlying tissue remains intact. They can result from blood vessel injury and are more common in operative deliveries. They can occur in the vulvar, vaginal, and retroperitoneal areas. Women with hematomas typically complain of deep, severe, unrelieved pain and pressure despite usual comfort measures. Hematomas should be suspected if the mother shows signs of concealed blood loss, such as tachycardia or hypotension, particularly when the fundus is firm and lochia is within normal limits. If trauma is the suspected cause of postpartum hemorrhage, surgical repair is necessary. Small hematomas may absorb naturally, but larger hematomas often require incision and evacuation of clots. Late postpartum hemorrhage, also known as secondary postpartum hemorrhage, is a hemorrhage that occurs between 24 hours and 6 weeks after birth. It is most commonly caused by subinvolution or retained placental pieces. Subinvolution is when the uterus doesn't decrease in size and return back into the pelvis, and it's more common in women with fibroids, endometriosis, or retained placental tissue. Retained placenta pieces also can cause problems of their own because they remain attached to the uterus and don't allow for the proper compression of that area to stop the bleeding. The risk factors for late postpartum hemorrhage include a manual removal of the placenta accreta, previous cesarean delivery, uterine leiomyomas, history of early postpartum hemorrhage, and advanced maternal age greater than or equal to 35 years old. The treatment for late postpartum hemorrhage is to control the bleeding, usually with medications and the removal of the placental fragments, usually done with a D&C procedure. Lastly, this slide gives you pictures of various levels of blood loss.